Thank you, Philip. It's a pleasure to introduce Karen. We've worked with her for several years now and have really appreciated all of her contributions and her wisdom, and particularly a wonderful debate with Mark Musin that she had, I guess it was a couple of years ago. At this meeting. So Karen, we continue to appreciate you.
Thank you.
Biographically, Professor Karin Verspoor is Dean of the School of Computing Technologies at the RMIT University in Melbourne, Australia. She's a fellow of the Australian Academy of Technological Sciences and Engineering and the Australasian Institute of Digital Health. She is also the Victorian Node Lead and co-founder of the Australian Alliance for Artificial Intelligence in Health. Her focus of research is primarily the use of AI methods to enable biological discovery and clinical decision support through extraction of information from clinical texts and the biomedical literature and machine learning-based modeling. So Karin, we are positively delighted to have you with us and looking forward to your presentation.
Thank you so much. Let me bring up my slides. Okay, hopefully everybody can see that. Can you see that?
Yep.
Excellent, beautiful. Okay, so I have taken the liberty. So Chuck originally asked me to speak about a particular topic, and I've taken the liberty of adapting the topic to something I've been thinking a bit about recently, and I'll tell you a little bit about more in a few minutes about the context in which I was doing this. But I thought it was opportune, especially in the context of Chuck's comments earlier about Gen AI and these sorts of things, for us to be really thinking about what it takes actually to build a computable model in the context of that evidence in practice. And so that's what I'll kind of be focusing on in this talk, with a particular emphasis on privacy. So that's really what I'm going to be talking a bit about. And I'll just preface my talk by saying I have some proposals and some ideas, but I actually have more questions than I have answers. So I'm hoping that some of you will maybe come on a little journey and help us figure some of these things out, because there are real opportunities here that we have some significant problems we need to solve before we can really take advantage of those opportunities. I would like to acknowledge the country that we're meeting on. This is something we do in Australia, and it's something that I believe is important. So just to acknowledge the people of the Woiwurrung and Boonwurrung language groups of the Eastern Kulin Nation, where I am at the moment presenting, but also to acknowledge the lands and the traditional owners of the lands where you are meeting from. So thank you for acknowledging these long histories of the peoples that have been here for hundreds of years. I also wanted to mention a disclosure, because I will be talking about privacy and secure data linkage, that I am a non-executive director of BioGrid Australia, which is a not-for-profit that provides some of these services. So, the reason I'm on the board is partly because I have some of this expertise, but I did want to just note that. Okay, so what I'm going to be talking about really is, the whole point of MCBK, which is trying to build computable models of biomedical information and knowledge, and in this case with a focus on real-world practice-based evidence that comes out of the practice of doing clinical care, health care. So I'm going to be focusing on models that are derived from real-world digital data, such as electronic health records. Don't talk to me about fax machines. I don't want to go there. Let's assume we have digital data. And models that are learned using deep learning methods. I think some of the points that I'm going to be talking about actually apply more broadly, regardless of what kind of models we're building. We probably need to be dealing with some of these issues if we want to be bringing health data together at scale. And I'm going to be focusing on capturing the patterns of healthcare healthcare as reflected in the data. And I'm not thinking exclusively about generative applications or predictive applications. I think the key point here is how do we enable our modeling of complex data, no matter what the intended purpose of those models is. So just to decode my infographics a little bit, this top thing over here is meant to be representative of a predictive model, and down here I was trying to reflect the fact that we can build a model from existing electronic health record data and then use it to generate synthetic or simulated or the next in sequence of other electronic health record data as well. So I'm agnostic to which applications we're using, but both of these types of applications at least are what I have in mind. Okay, so I think Chuck actually already said this, but there's an argument to be made that LLMs, the large language models, are arguably the most computable form of knowledge that we have at the moment, and that's because it's capturing the patterns of language, and language is a primary mechanism that we use to communicate information. And arguably, all of the knowledge we have, at least in science, is captured in linguistic form. The main vehicle by which we communicate scientific information is scientific papers. And so if we can build models that are capturing the language that's in those scientific papers, then we are doing a phenomenal job of capturing the knowledge that's embedded in all of those words. And large language models, as we probably have all discovered, really integrate a huge amount of information and allow us to build these models where we can access, at least in principle, the knowledge that's embedded within them through mechanisms such as prompting. And I'm actually not going to get into a lot of the debate, which I had actually with Mark a couple of years ago, around the quality of those large language models and the potential for risks and problems in generative applications. Because that's another whole talk. But I think it's worth acknowledging that really these models are extremely large. They capture a huge amount of very valuable information, and they're extremely powerful. And so we want to see whether we can take advantage of these types of models in safe and responsible ways in healthcare settings. And so one place we can look for data that can become part of either a language model or some other kind of foundation model that integrates both structured and unstructured information is, of course, our electronic health records. And so, these electronic health records, you're all aware, are hugely valuable, right? They capture the full history of the patient journey through their health care. And it's capturing diagnoses and treatments and all sorts of information. And so they're extremely valuable for any kind of data-driven or knowledge-driven kind of medical research. If we can turn that data that's captured there into knowledge, then we really have access to a level of detail about how patients progress, how disease progress, how treatment, what treatments are effective, and those sorts of things. And so it's really a valuable resource for us to tap into in the context of trying to mobilize computable biomedical knowledge. Unfortunately, this data is extremely difficult to collect. The electronic health records themselves are not collected primarily for research purposes, and as a result, we haven't consented the use of this data for secondary purposes, and access is typically very, very tightly guarded, with good reason, because this is extremely sensitive data as well. But also because there are legal frameworks which govern the use of that data, and HIPAA and GDPR, for example, mandate de-identification of data before it can be shared, including for research purposes, which creates some hurdles for us in trying to access this data. Something that I think is important for us to see as kind of an objective in this is trying to capture the actual patient journeys that are represented in that data. So this is kind of a timeline of events that's associated with a particular patient's journey through the healthcare system. And we can map out on that timeline, diseases and drugs that have been administered and lab measurements that have been taken and procedures that have been performed, and kind of see this story on the timeline about events that relate to the patient's health. And the power of this is that we can then start to analyze those journeys for insights into evidence that relates to the kinds of questions I asked earlier, through sometimes just simple clinical characterization, counting things up, how often something occurs, but also moving into that kind of patient level prediction sort of modeling. So we can ask questions once we have data in this sort of form about, which treatments patients choose after a particular diagnosis, what patients choose what treatments. So, what are the demographic or clinical characteristics of patients that choose particular treatments, and what outcomes do they then have after those treatments. We can start to ask some more kind of statistical questions, like, does a treatment cause a particular outcome, or does one treatment cause the outcome more than the alternative, by looking and interrogating at the real data that's happening in the real world, which gives us an advantage over, say, clinical trials, where actually many of the aspects of the real world are oversimplified with reason, but we can arguably derive much more meaningful information and knowledge by looking at the real data in the real world scenarios. We can then move into individual level prediction and start modeling things like, what is the probability that this particular patient, given their set of characteristics, their set of events, will develop a particular disease, or the probability that they will have a certain outcome, perhaps after a particular type of treatment. And this is really powerful modeling that can ultimately support clinical decision making. One thing to note about those electronic health records, of course, is that they have lots and lots of text in them. And, there's a list of them on the slide. Some people have estimated that up to 70% of the electronic health record is in free text form. I have also heard numbers up to 90%. I'm not sure exactly what the evidence for that is, and it probably depends on how you count, because, for instance, images are much bigger in terms of volume than a text. But perhaps it relates to the proportion of the electronic health record for an individual that is captured in text form. Regardless of whether it's 70% or 90% or even 50%, I think it's really important that we acknowledge that this data is there and that we don't just ignore it, which is what we have typically been doing, because unstructured data is messy and hard to work with. But now that we have these language models, it behooves us to think about how we can leverage that paradigm in the context of our electronic health record data. So I'm revisiting my patient journey and adding notes into the picture, because we really need to be thinking not just about those events, but also about all of the words that describe the nuance of a particular patient journey and a patient situation. Clinical text, once we start working in this context, poses particular challenges for us in terms of data-based modeling, because our protected health information or our personally identifying information can appear basically anywhere in this text. And so it raises substantial privacy concerns. The typical response to this problem has been that people simply say, no, you cannot access this text data. It's too sensitive. We might be leaking our personally identifying information. And from my perspective, this is simply wasteful and not acceptable. And so I think we need to address the problem of identifying personally identifying information in this text in order to be able to make meaningful use of an extremely valuable resource. You know, if it's 70% of the electronic health record, we really should not be throwing it away. There's a huge amount of information there that can contribute to our knowledge and understanding of those patient journeys and disease outcomes and so on. So people have tried to approach this problem of doing text de-identification by treating it as essentially named entity recognition problem, which means we're trying to hone in the context of the natural language text on names and dates and ages and addresses and so on, the whole list of personal identifiers that may be captured in the text. And with an objective then of either of redacting that information in some way. And one way that people do this is to simply block it out. You know, Mr. XXXXX who lives at XXXXXXXX has an acute infection of the lung and so on. Another strategy which is sometimes used and arguably more effective is to actually substitute the identified names with alternative names, which is really a way of addressing the problem that we know that no technology for de-identification, or really any technology, is going to be perfect all the time. And that's particularly true in the context of natural language text, which is quite messy and variable and unpredictable. And so while we can have some confidence about our ability to de-identify structured data when we know that there's a name in a particular labeled field, like name, or date of birth in a labeled field, it's a lot harder in the context of text. And so if we try to substitute the information, the advantage of that is that if a name slips through the net, or a date of birth slips through the net, then we won't know whether it's a real name or a surrogate name. And so this is a strategy that I think gives us some real advantages. So there have been some efforts to build de-identification methods over the years, and this is just a brief snapshot of them. But we started with essentially rule-based methods, which try to detect names and dates following patterns in the early work, and then we have moved over time towards more statistical models, neural networks, and of course now people are experimenting with the use of large language models for doing this task. Again, none of these systems are ever going to achieve perfection, and we should acknowledge that, but they are definitely improving. There is one system that I'm aware of that has been certified for use in clinical data modeling, which is from UCSF, San Francisco, called Filter. And what Filter does is essentially use a combination of known names and regular expression patterns, plus white lists of medical terminology, in order to essentially capture all of the things that we know are names, and then allow the terms that we know are not names to pass through. And so this is a kind of a colander approach to doing de-identification. It provides us with a way of ensuring that we're capturing the PHI as accurately as we can. And as you can see, maybe it's a little small, but if you can see on the right, the approach that they're taking in this particular instance is to redact the information. So we have those stars replacing the real information. As I said earlier, I think I would prefer a substitution approach, an obfuscation approach, but nevertheless, either of those are valid options. I wanted to just touch on the privacy of research data sets. And there has been some discussion of this in the literature. I'm pointing here to some work by Murphy et al., where they identified 3 dimensions of privacy and what it really means. Privacy, to some extent, is the quality. I alluded to the fact that these de-identification methods are never going to be 100% perfect. We can't expect them to be. We can get them pretty close, but probably not completely perfect. But there's also the dimension of trust in the researcher, or in the research, or in the model building that we are doing with these data sets. And security is also a key part of the equation. So in order to engender trust, we have to have mechanisms that ensure that only people that we trust have access to the data. And so trust and security go along with quality because of the fact that if it's an imperfect de-identification method, we need to ensure that we are protecting the data as far as possible. And this will really actually form the foundation of some of the proposals I'll come to in a few minutes. I do want to raise the question about whether we have an ethical or social imperative to share data for research purposes, given our objective to extract knowledge from these data sets. This, of course, does raise the question of how we establish that imperative. Like, do we really have this imperative? And I think actually some collaboration with some social scientists and other researchers will be really valuable here, so that we can really identify how the public feels, right, about their data being shared for the purposes of building models. And it comes back to communicating the value, like what are they going to get in return for going on this journey, and recognizing that there is always some risk in this process. And of course, the cybersecurity, right? So we need to be thinking about when we build models from this highly sensitive data, what are the risks that we're taking in terms of even if we're doing de-identification, what are the risks of re-identification? How can we protect against membership attacks, which are basically trying to find people in the data? And of course, we have under some of our legal frameworks the right to be forgotten. How does that interact with how we're building these models? These are, again, not questions I have necessarily answers to, but I think things that we should be talking about. There is also a body of work that relates to what's known as privacy preserving machine learning, and federated learning is one key approach that has been explored in this, because sharing data across jurisdictions, even between a general practice, a primary care doctor, and a hospital, is often fraught in many places. And sharing just basically is hard, but in order to realize the opportunities and the value of the data, we really do need to find ways to share them. And so people have been exploring federated models, where essentially you build local models in a local data context, and then you share the model and allow some learning or feedback to happen in order to create a global model, rather than sharing the data sets directly. And this works really well in structured data. It allows us to abstract from the characteristics of the data into these local models and share that out. But it's not clear to me how well this transfers to the concept of a large language model, where we have such nuanced patterns of language that are captured in there. And when 70% of our electronic health record is text, this is really a question we need to be thinking about. And so I hope that some researchers will take on the challenge of thinking through how we can adapt the federated learning paradigm into the context of electronic health records, where we have text as a major component. I will note that some of the impetus for doing this is that the data sets that we have available to us in research, and arguably for building AI models in healthcare at all, that involve anything to do with that really valuable text resource, are very limited. So I put a snapshot of some of the key data sets that people have been using in clinical natural language processing, building on data mostly derived from one healthcare system, which is Partners Healthcare in Boston. Now we see also some data sets that are and models that are being derived from Stanford Health System. But for those of us in APAC, thinking about the fact that all of our AI models, all of our clinical natural language processing models are being developed and tested on exclusively US data, raises a bunch of questions about how well the models, or the knowledge models that are derived from these data sets, will transfer to our context. And I would suggest that even transferring from Partners Healthcare to Stanford Healthcare probably has some challenges, let alone transferring from the US to the context of Japan, where there's a completely different language in use, or Australia, where our documentation and funding models are extremely different from the US context. So perhaps maybe we can think about sharing models, as I said, in that kind of federated learning approach. Maybe we can think about building models and share those out rather than sharing actual clinical data. And we have a couple examples of this. So Gatortron from University of Florida is a language model that has been based on their health system. And at Stanford, again, in addition to releasing some data sets, they have released some pre-trained clinical models. Now, in this particular case, Climber, it actually doesn't include any text. So it's a language model in the sense that it is a sequence model looking at the patient journey and the events related to the patient journey, but it doesn't include the notes, at least so far. So even if we think about sharing models, we don't have many examples of that to date. And that's partly because of the privacy concerns that we have, particularly, again, with the language models, where we're memorizing training data, and that opens up the risk of having privacy leaks. We also need to be worried about how we can adapt these models to the context of other languages or other health systems. And if we don't really know how these models were derived, or much about the populations that are represented in the data, we have the risk that there are significant biases in the data, or at least things that don't match or don't align to the populations where we want to use these models. So all of this is pointing to us really trying to do a better job of sharing data, getting access to data, so that we can build models that are more localized. One concept is the notion of synthetic data. And, in principle, the best way to preserve privacy is not to use private data at all. And if we could share data in a way that doesn't rely on that private data, then that would get around all of our privacy problems. And again, synthetic data generation is a strategy that is used in many structured data contexts. However, it relies on knowledge of the statistical distribution of the data, so that essentially records can be generated that look like real patients following the natural distribution of the data, but aren't real patient data. And I think for us in the clinical text space, this creates some challenges, because arguably we cannot obtain that level of distributional knowledge about the language used to describe patients without actually seeing examples of the language used to describe patients. So we have this kind of, enabling requirement of having actual examples of relevant data in order for us to be able to drive this process of synthesizing data. Okay, so where are we headed? At the moment, what we have is computable models mainly derived from public data. Sorry, there's something in the chat. Should I be paying attention to? Can't quite see it. These are primarily based on information that's out on the open web, right? And or information that's captured in databases like some clinical registries or biological databases that are available to us and can be accessed without these kind of security or privacy concerns. However, the kinds of models that we're building from this data don't capture those specific characteristics of individual patient journeys. They're limited to kind of idealized clinical scenarios, textbook and scientific knowledge. So what we want to do is really, and this is really the crux of it, and I guess I'm talking too long, so I probably should get to the point quickly, which is really to think about us having a series of transformations of data that allow us to move towards having an obfuscated model, which can be shared and utilized for driving all sorts of predictive and generative applications. And so, we need to acknowledge that at some point, somebody needs to have access to the raw data in order to be able to map it to de-identified data. But what we want to have is a framework in which the most trusted people only have access to the raw data. And when we're thinking about sharing data, we need to be thinking about what it is we're sharing. Do we need to share the raw data? It depends. I'll come back to that in just a second. Or can we get away with just sharing de-identified data or obfuscated data or obfuscated models? And there's a bunch of methods. I won't spend time going into each of these, but the idea here is to have kind of a series of different transformations of the data that increasingly make the data more free. In order to build patient journeys, like I described before, we do have to have secure data linkage at the patient level. If a patient is moving through different parts of our health system, we cannot connect their journey up without knowing who they are in each of those individual data sets. And so arguably, again, at that raw data level, we do need to be facilitating some data linkage in order to allow us to build these kinds of models. When we're talking about building models across patients or across healthcare systems, the story is a little bit different. We don't need that individual identified level of raw data. And so we can move into, I would suggest, at least the de-identified or obfuscated level, but how far we can go, I think, is still an open question. And there are probably different models for aggregation that we can explore in this context. But again, I don't know if all of the answers that we have in place for structured data will transfer neatly to the context of text. So these are things we need to investigate. I will say that there are obviously other enabling conditions that will allow us to move towards these kind of large scale models of clinical knowledge. Electronic health records being the most obvious one, but there are also other essentially governance strategies that we can use that allow us to have more insight into what is in the various data sets and the various models that we are building. And for research purposes, we've had proposals including tripod plus AI, tripod LLM, which dictate what researchers should be telling you about how they're building their models and what data they are using for that. And then there are corresponding things such as data sheets for data sets and model cards for model reporting that are related to that idea. And we have ISO standards that also need to be followed in order to implement the secure access to the data, and of course, health information modeling. Okay, so wrapping up, I hope that I have convinced you that building detailed patient-level computable models of healthcare is possible, but also extremely valuable, and that privacy of that data is paramount. So the whole point of this talk really is to explore how we can find ways to share patient data safely and securely, because we don't want to miss the opportunity to build these models from real patient data. And we don't want to have to throw out the text that's in there, because it is so much an integral part of the way we practice medicine, is to capture information in language, in linguistic form. De-identification is part of the answer as an enabling technology, and we need to be thinking about those access models for tapping into this data. Ultimately, the models that are effective to produce synthetic clinical data may be our best resource, but there's no way that we can get to those synthetic data models without seeing some realistic clinical data along the way. And how much of it we need and who can build those things is something we still need to figure out. So I told you I would tell you what inspired this talk, and I had the amazing opportunity to spend some time in Japan, sponsored by the National Informatics Institute of Japan, um, um, in a room in a retreat center for a week. Just recently, and I spent a lot of time discussing these topics with the people whose names you see on the slide. It was a really, really inspiring conversation and led us to the model I've shared with you. And we are working on a paper. So one day you will see these things come out in paper. So with that, thank you. And I'm happy to take any questions.
Yeah, you're on.
Yes, Karen, thank you so much for this presentation. We always learn so much from your ideas and insights. Are there any questions in the chat for Karen? We will check and see. And I don't,
Yeah, there's one just come in.
the one just come in. Oh,
It's a long one.
it's a long
Okay,
one.
I'm
Oh,
reading.
yeah. I'm just gonna read the question, which is, thank you for the introduction. Diana, we'll just read your question here. From your perspective, what are the main challenges and potential strategies to achieve interoperability and unified health data in Indonesia's digital health ecosystem? Additionally, within this dual system context, which type of data would be more effective as the foundation for developing data-driven models or AI-based decision support in healthcare? Repeat that.
It's quite a complex question, Diana, and I think we probably maybe need to have a follow-up conversation to work through it. But look, you're exactly right that one of the key challenges is accessing data, and I'm sort of the opinion of like, let's just get started, right? So find the frameworks and the approaches that allow us to start making progress on this problem. It is a journey, right? We're, sorry to use the journey, patient journey, our journey, but we are on a journey. And I don't think I have all the answers. I've raised a lot of questions. And I don't think, there are easy answers to some of these questions. And we just need to start trying, because if we don't, we won't actually understand the full complexity of what's involved. We can think about governance frameworks. So we do have examples of that. BioGrid, the organization that I'm working with, is trying to manage that in the research data space. There are ways that we can get people together and really talk through these issues around what is the level of trust, what is the level of security, who should be doing this, right? That we want to give access to. But what I think we don't want to do is get it 100% right before we start trying to get down go down this road, because we'll be waiting forever, and we'll be missing the opportunities that we have right in front of us. So we have to balance our risk with the reward that we can get from doing this. And I think the other aspect of your question is like, do they need to be fully interoperable? Look, I mean, this is one of the beauties of large language models or these deep learning models, is that, in principle, how well it works, you can do some research, but in principle, we can just throw the data in, and the models will find some sort of patterns in there. It might be too messy, but I think again, rather than waiting for perfection and fully, OMOPed clinical data, it would be better to just get on with trying to learn some patterns from this data.
I just want to come in on top of your response, Karen, to say that one of the most common reasons given to me for not pursuing this kind of work or not pursuing learning health systems is that our data are not perfectly standardized, and not until we have our data perfectly standardized, will we be able to do this? And that
No,
statement is paralytic.
absolutely.
And I think that I would just really second what you said about jumping in, doing the best you can with what you have, learning along the way and improving your methods.
I mean, I didn't land on this de-identification stuff by accident. It was because, I'm an NLP person. Like I've been doing NLP for whatever, 25 years or something. And most of the time when I go into clinical situations and I say, hey, you've got a whole bunch of text in your clinical environment, would you like to share it and give us access to it so we can start doing some useful things with it? Mostly the answer has been no, too risky. There's names in there, there's personal identifying information. And as you said, Chuck, it's paralytic. It prevents us from doing anything. And I just think in today's world, that's not acceptable.
Yes, agree. And I think as we think about what might be possible in less resource nations, low and middle income nations, I carry the same message. Do what you can with what you have and learn from that. And as more resources become available, you can apply them. And in fact, the progress you make can create a demand for more resources because you can say, look at what we've done. If you give us a little bit more, we can do more. So this idea that perfection is a precondition for doing anything. Paralytic is the only word I can use.
Exactly. And I can give you a good example of that. So we had a collaboration with the Murdoch Children's Research Institute, which is attached to our Royal Children's Hospital here in Melbourne. And they had reason for visit, basically referral fields that were free, small free text fields. And there's occasionally there's sensitive information in there, but not really. It's mostly just has fever or UTI or whatever, things like this. And we built a really small classifier that just mapped it into different units in the hospital. And that then enabled a whole bunch of research around why patients were coming into the hospital, what the resources that were being used. And, before they had this kind of categorization system, they couldn't do anything with that data, and the data was just ignored. So it's enabled a whole bunch of essentially population health research about utilization of primary care and connections into the hospital that wouldn't have been possible without dealing with the text. So yeah, we need to just start doing stuff.
So we do have one more question, and we'll keep the discussion going through this question and then go to a break. Anne wrote and asked, is there a working group working toward these de-identifying pipelines that you mentioned, and especially on a policy level, given that we are working on the other direction of having the data entered in a better quality?
So I don't know of a working group. If you know of a working group, or if you find one, let me know. I think, there, as I said, there's been research in the NLP community, also supported by I2B2, on de-identification for many years. I mean, I think the I2B2 de-identification track goes back to the 2011 or something like that. So there have been people trying to work on this problem because it is so important. Whether it's at the policy level, I think, we're really only at the beginning of this process of convincing people that we need to be tapping into the text. And so really until not too long ago, the response simply has been, no, too hard. And you can only do it in really controlled circumstances like the University of California, San Francisco example. And I think, it is time that we just tackle it for the broader community. And that's what I'm trying to do by giving this talk.
Thank you so much.